Good morning, everyone. I am Artis Hoban, President of the American Medical Association, and it is my pleasure to welcome you to this very exciting presentation today. We are honored today to host Sir Michael Marmot, who will talk to us about the social determinants of health. The AMA's Improving Health Outcomes strategic focus area, in collaboration with the AMA Office of International Medicine, is the driving force behind this event. As the AMA embarks on its journey to improve health outcomes, understanding and addressing social determinants of health will be critical to our success. As many of you know, the social determinants of health are the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces: economics, social policies, and politics. Sir Michael is widely regarded as the world's foremost expert on social determinants of health. He is past president of the British Medical Association and is currently the director of the International Institute for Society and Health and research professor of epidemiology and public health at University College London. Among other international posts, he chaired the World Health Organization's Commission on Social Determinants of Health in 2005, and is current chair of the World Medical Association Socio-Medical Affairs Committee. His accolades and affiliations are too numerous to recount here, but among them, he was knighted in 2000 by Her Majesty the Queen for services to epidemiology and understanding health inequalities. And in 2007, he received the CDC Foundation Hero Award for his groundbreaking work examining how socioeconomic status impacts health over a person's lifetime. Sir Michael will give his presentation, followed by time for Q&A, with a hard stop at 11 o'clock. I encourage you to take advantage of this rare and important opportunity to engage with Sir Michael. He is eager to share his expertise and help us advance our understanding of how the AMA can positively impact social determinants of health. I am now proud to present Sir Michael. Thank you for joining us.
And what a pleasure to be here at the AMA in Chicago, talking with colleagues about how we can take this agenda forward. I want to focus particularly on the role of health professionals. I spend a lot of time talking to politicians, people in different branches of government, people involved in child care and child services, but I want to talk about the role of health professionals. Now, I've spent my academic life looking at social determinants of health, by and large arguing that the key determinants of health are not what doctors do to patients. They lie outside the healthcare system. In the US, much of the discussion about disparities in health is about disparities in healthcare. For good and obvious reasons, that is a concern. But my concern is exactly as the President said in her introduction, with the conditions in which people are born, grow, live, work, and age, the social determinants of health. My reward for saying that doctors were irrelevant to this was to be made president of the British Medical Association. I think we'll shut him up somehow. So I took advantage of that to say, maybe I could involve the doctors. Wow, what an idea, that the doctors could get engaged. And I will talk to you about the fact that the doctors can indeed get engaged. Now, when we were preparing for this, AMA colleagues told me that you are concerned with heart disease and diabetes and what you can do about that. So I will say a few words about that and how what I'm talking about will relate to those concerns with heart disease and diabetes. To bring you up to speed, I chaired the WHO Commission on Social Determinants of Health. We published our report in 2008. And we called it Closing the Gap in a Generation. Ambitious. We referred to a 44-year gap in life expectancy across the world, as big as a 28-year gap in life expectancy within countries. And we called our report Closing the Gap in a Generation. It was a statement that we had the knowledge to close the gap in a generation. We had the means to close the gap in a generation. The question is, do we have the will to close the gap in a generation? Robin asked me a pertinent question. Is anybody taking this seriously? She didn't quite put it like that, but that was behind the question. It's all very well to produce a report. We know what happens to most reports. They get forgotten. The half-life is about 3 months of reports. Then they're gone. Well, the government in Britain commissioned me to do a report of inequalities in England, asking how could we apply the recommendations of the WHO Commission in one country, in England. It's known as the Marmot Review. We called it Fair Society, Healthy Lives. And that title was chosen advisedly. It was a statement that if we put fairness at the heart of all policy making, health would improve and health inequalities would diminish. Isn't that a radical idea? Put fairness at the heart of all policy making. Conduct policy making in a spirit of social justice. Who ever heard of such a thing? Policy making is about balancing special interests and who pays the most money, isn't it? God, look what happens when academics enter the policy space. They start to, Dr. Madeira said, that was asked, was this going to be more like, what was the thing, going to church, or going to the theatre, he said, people compete to get there early to get the front seats, and at church they get there early to get the back seats. And he wanted to know, was this going to be more like the theatre or the church? And I said, maybe it should be more like the church. Let's all join together in a spirit of social justice, including the people in the front seats as well as the back. And I'm all excited because on Monday, what's today? Wednesday. On Monday, I was in Turkey at the regional committee of the World Health Organization for Europe, and we launched our European review of social determinants and the health divide in the WHO European region. When you do one of these things, it takes 3 years, and when you finally hold it in your hands, I'm excited. But it means we've got 53 member states engaged in this issue. And I will indulge myself and just say a few words at the end about the European review. Now, you're concerned with heart disease and diabetes. We published this in that little journal called JAMA, that's the one. Don't tell Howard I said that. I'm seeing him this afternoon. Looking at illness in England and the US. These were people aged 55 to 64, men and women. We confined it for technical reasons to white men and women to make the comparison. And the Americans were sicker than the English for 7 major conditions. I put heart disease and diabetes here. And you can see the Americans had more illness than the English. And in both, there's a social gradient by income. The higher the income, the lower the prevalence of diabetes, the lower the prevalence of heart disease. So both the international comparison says we both have a problem, but you've got an even bigger problem. And there's a social gradient. I'll show you mainly British data, but it's a fair bet that everything I show you about Britain applies to the US and then some. This is circulatory disease death rate at ages under 75 by the deprivation level of the local ward. So divided into 20ths. This is the most affluent, the least deprived, and that's the most deprived. This is very important. This is very important. It's possible to think that inequalities in health are confined to poor health for the poor. Or if in the US context you think of disparities as being particularly racial ethnic groups and everybody else. What the gradient is showing is it's not confined to the poor there. It's a remarkable stepwise relationship. And the implications of the gradient are profound. If you think the problem is poverty in health, firstly you have to recognize that the poor in Britain and the United States are fantastically rich on a global scale. $1.25 a day? Who in the United States or the UK lives on $1.25 a day? Nobody. That's the global poverty line. 20% of the world's population live on $1.25. So we're all fantastically rich. But we're relatively deprived the lower down we are. And the gradient means that if we want to do something about inequities, the unfair distribution of health, we need to be striving to bring everybody up to the level of the best, not focusing only on the worst of, but the second best have higher mortality than the best. And hence our logo. Somebody can explain our logo to me afterwards, but that's the point of our logo. Obesity, quintiles. Most deprived, least deprived. It's a gradient. The more deprived, the higher the obesity level. This is in children, aged 10 to 11. Now the other thing we have in England, and I would be very surprised if you don't have something very similar in the US, is that there's an intersection between where, in fact I know you do have the same phenomenon in the US because I've seen the data. There's an intersection between where you live and your own level of income or education. So, for example, in London, the bottom quintile have particularly high obesity levels. For the top quintile, it doesn't seem to matter much where in the country you live. The lower you are, the more it matters where you live. So it's where you live and also your characteristics of education and income and so on. And I think I may not put this slide in, but we've got data about the density of fast food outlets by deprivation of area. You don't have McDonald's here, do you? If you look at McDonald's, KFC, and some other guy, I get indigestion just thinking, and Pizza Hut, that's right, it was McDonald's, KFC, and Pizza Hut, great British food outlets. The more deprived the area, the greater the density of fast food outlets. And we blame people in deprived areas because that's what they eat. What else is there to buy? So you can see this intersection between your own level and where you live. Psychological distress and subsequent obesity from my Whitehall 2 study of British civil servants. The greater the number of times they were classified as a case of depression or anxiety on the general health questionnaire, the greater the odds of being obese. Feeling rotten about yourself is related to obesity. I'll skip over that. You're also concerned not just with diabetes and heart disease, obesity. Here's alcohol. Alcohol is really interesting. You've got to be a real nerd to say something like that. I'm a nerd, what can I do? Alcohol is interesting because alcohol, certainly in Britain and many other countries, and probably the US too, is more common as you go up. People in higher status drink more. particularly women. The upward social gradient for alcohol is stronger in women than men. High status women drink more than low status women, and it's a gradient. High status men drink more than low status men, it's a gradient. It is not the case that poor people drink more, they can't afford it. But harm associated with alcohol follows the gradient. The greater the deprivation quintile, the greater the alcohol-associated harm. So it's not just the alcohol, it's how you drink it, it's what goes along with alcohol, poor nutrition, the company you keep, and so on. So drinking a bottle of Beaujolais every night with dinner is one thing. Drinking the equivalent on Friday night is something altogether different. And mental illness. Social classes 1 and 3, non-manual, higher, lower for men, and for women, higher rates of mental illness, but again, the social gradient. Everything we look at, everything that doctors are concerned with, the common conditions, heart disease, diabetes, obesity, mental illness, alcohol-associated problems, all follow the social gradient. You cannot deal with these issues and ignore that. So, in my English review, we had 6 domains of recommendations. To give every child the best start in life, education and lifelong learning, employment and working conditions. The 4th one's another really radical recommendation. In a rich society, everyone should have the minimum necessary for a healthy life, which you can calculate. Healthy and sustainable communities, and a social determinants approach to prevention. So not just saying don't smoke and don't be fat, but how do you take a social determinants approach? What can health professionals do with this agenda? So we produced this report, which colleagues here had, and I brought a small number on flash drives that people can have. And this followed from my time at BME of the role of health professionals. And we said there were 6 areas of action. The first is workforce education and training. And of course, I'm not going to go into what to teach them because that's everything that I'm talking about. So let me just give you some key examples. Early childcare and education. The importance of parenting and family support. I'm talking to the gynecologists and obstetricians tomorrow here in Chicago. And I will say to them, as I said to the gynecologists and obstetricians at the Royal College in London, your job is to get a healthy baby out. Do you care what happens after that? Is it any part of your responsibility to care about unwanted teenage pregnancy? Is that part of your responsibility? Is the nurturing of babies part of your responsibility? That baby is going to grow up to be an adult and become a parent, a mother or a father. And what happens in those early months and years will determine the kind of parent. Do you care? So I challenged them, and at the lunch afterwards, and I'm used to this, one person said, that was terrific, but nothing will happen. Believe me, nothing will happen. It won't make any difference. Standard circles. The president of the Royal College invited me back 3 months later for breakfast. And he said, we've taken to heart what you said. We think our Royal College should be the advocate for women's health through the life course. Wow. I said, would you consider changing the name of the Royal College to the Royal College of Women's Health? That was a step too far. But still, to have a fusty, fuddy-duddy Royal College say we should be the advocate for women's health through the life course. And that's what we're going to teach our obstetricians and gynecologists in training. That teenage pregnancy is their concern. The factors that lead to teenage pregnancy. The quality of early child development is their concern. So are the general practitioners and the paediatricians who are natural allies in this. And give you one example. If we look at socio-emotional difficulties at age 3 and 5 with children, it shows a gradient. The poorer the parent, the more likely are children to have socio-emotional difficulties at ages 3 and 5. You're getting the point about the gradient of this message. It's not just the poor, it's graded. And socio-emotional difficulties at age 3 and 5 predict subsequent mental illness and physical illness. Crucial. Can you do anything? Well, yes. We got a parenting school. We asked parents, is it important to talk to a child? Age 3. 20% of parents denied that it was important to talk to a child age 3. We said, is it important to cuddle a child? 20% of parents denied that it was important to cuddle a child. Parents know about parenting. We asked about playing with children, singing, activities, things you do with children, that are good for parents, let alone good for children. Reading to children. What more beautiful experience is there in the whole world? Dig in the ribs, wake up, Daddy, let's get on to the next page. We see a social gradient, and when we adjust for those parenting activities, it reduces the social gradient in social emotional development. And I've said that we see the social gradient in reading to children, and I've said if parents are ground down by misery and poverty and are scarcely literate themselves, the evidence shows we can make a difference. Good services make a difference. And the poorer, more deprived the family, the greater the impact of the services. And I said this to a group of health people and local government people, and a chief executive of local government leapt to her feet and said, we should implement this afternoon. What are we waiting for? Well, this is dealing with, it's actually working in partnership, but it's dealing with the issues of individuals. Let's look at the other end of life, at older people. Social isolation and loneliness is associated with 50% excess risk of coronary heart disease. And people at older age, the lower they are in the hierarchy, the more likely they are to report loneliness and misery at being lonely. And we know, if we look at areas, the more deprived the area, most deprived, the more likely are people to report lacking social supports. Services make a difference. Now, I said NHS organisations, but the healthcare sector, if your healthcare sector is 18% of your gross domestic product, it employs a lot of people. A lot of people. So the quality of work in the healthcare sector is something that health professionals can get involved in. Stress at work. We've been looking at high demand, low control, and effort reward imbalance, and social isolation at work. And stress at work is associated with a 50% excess risk of coronary heart disease. You have a concern with heart disease? Here's an intervention area. Improve working conditions for people who work in the healthcare system, something that doctors can be involved with. And if we look from our Whitehall study, the association of grade in the civil service with job control, the higher the grade, the more likely are people to report they have control over what they do. And having control over what you do is a potent predictor of coronary heart disease, of mental illness, and of sickness absence. People who feel disempowered get sick and don't come to work. And they probably don't work very well when they're there. So, an important issue. And we show that the more exposures to isostrain being a combination of high demand, low control, and social isolation, the more likely are people to have the metabolic syndrome, precondition for diabetes and heart disease. And look at job strain and subsequent weight gain. People who have high body mass index under job strain, high demand, low control, are likely to put on weight. So if you're a bit overweight and you're under stress at work, you put on weight. If you're low BMI at baseline and you're under strain, you lose weight. There's an intersection. Stress leads fat people to get fatter and thin people to get thinner. So it's not just simply that it relates to obesity, it goes both ways depending on where you were to begin with. Working in partnership. Now, in a way, 4 and 5 are together, working in partnership and working as advocates. When we published the Marmot Review in England, and it relates to the question Robin asked me, she's not a challenging person, but it was a good question. Is anybody taking this seriously? Is anybody doing it? My colleagues tell me 3/4 of local governments in Britain or in England have Marmot implementation plans. They have plans. I was saying to Robin, I met somebody from Manchester who said, oh, we talk about implementing Marmot all the time. I didn't realise you were a person. Implement Marmot. And I used to go around the world saying that at a meeting, the Norwegian Minister of Foreign Affairs said, I am a health minister. Every minister is a health minister because what we do in our day job impacts on health. And I got a phone call from an official in the Norwegian Ministry of Health and said, you know, you've been quoting our Minister of Foreign Affairs saying he's a health minister. Yeah. He now is our health minister and he wants to meet you. So I went to Oslo to meet him and he said, I've just come with some unpronounceable Norwegian name from a county in southern Norway, and they told me, I met the local government people, not the health people, the local government people, and they told me they have plans that are Marmot certified. So this is serious. People are taking this seriously all over Europe and Brazil and Chile and elsewhere. So one of the things, though, we think is important is to monitor. And we set up a monitoring system in England for 3 indicators of social determinants: early child development, the proportion of young people not in employment, education or training, and an adult poverty measure, and to monitor them by local authority deprivation. So what you can see, the least deprived, the most affluent, have the best early child development. This is the percent of children who are achieving a good level of early child development at age 5, and that's the percent of children who are good at age 5 in the most deprived. And you see this relation. I showed this graph in the Parliament, in the House of Commons, and one observer said, I think the multiple R squared in that regression equation is quite low. This is what politicians most want to hear discussed, the proportion of variance explained in multiple R squared. I said, translating that into English, what you're saying is there's variation around the line. That suggests there are 2 strategies. One is to bring the level of social and economic deprivation of the worst of up towards the top, to reduce inequalities in society. Does anybody in this room think that the United States would be better off if there were more inequalities? Does anybody? There are probably 1% of the US population who thinks that. That's the top 1%. But the other 99% don't think that. Nobody thinks that. Who the hell thinks that? So one way to reduce the inequalities in early child development is to reduce inequalities in society. But just in case that doesn't happen tomorrow or next week, there's variation around the line. And you can ask the question, as we have done, what are the ones doing that put them above their peers with similar level of deprivation? And there's good evidence-based answer to that question. I'll come to that in a minute. But I was really struck that the average was 56%. That's really shocking. Only 56% of children in England were classified as having a good level of development at age 5. Can that be true? Well, regrettably, it could be. This is UNICEF, the children's organisation, their report card 9 from a few years ago, that ranked countries on equality in child well-being, material, education and health. And these are the ones that do best with the least inequalities in child well-being: Denmark, Finland, Netherlands, Switzerland, Iceland, Ireland, Norway. Heavens, the UK's got to be somewhere. Oh yeah, there we are. I do like coming to the United States. It's the only place I can feel that we're halfway decent in the UK. Congratulations. You rank at the bottom on equality in child well-being. So that 56% figure is actually regrettably credible. We're failing our children across the board. And so are you, but even worse. And if we look at the latest report card 13 from UNICEF 2013, the early 2000s, US and the UK, for some bizarre reason, we got a bit better. But I'm sorry to say this, but you haven't. And this is 4 dimensions: child well-being, material, health, education, and behaviours. Can we do anything? Well, yeah, we can actually. Now, this is a slide I showed them in Turkey on Monday. I showed the 53 ministers. The government policy makes a difference. This is child poverty, where poverty is defined as less than 60% median income, before and after taxes and transfers. So if you look at Latvia, child poverty before taxes and transfers was at around 35%, 34%. In Sweden, it was 32%. After taxes and transfers, child poverty in Latvia was about 24%. In Sweden, it was 12%. In Slovenia, which is not a rich country, that's one of my great allies on social determinants of health, it's even lower. So there's a great deal you can do, because child poverty relates to parenting and the quality of early child development and so on through the life course. And government policy makes a real difference. Where's the US on this? This is 50% median income. Well, you're just a bit below Latvia, actually, between Latvia and Romania. I love coming to the United States. I have friends and colleagues here. I'm an Americanophile, or whatever the word is. But you are not doing well. I say that we in Britain are failing our children on a grand scale. You are failing your children on a grand scale. And government policy can make a difference. You could do better than Romania and Latvia. You have the money. It can't be lack of money that you've elected to do that. Clearly, you don't care about children growing up in poverty. I don't know whether this is the front seats or the back seats. The performance or the moral. I think it should be a moral conviction to get children growing out of poverty. You can say health is a matter of personal responsibility. So it is. But it's not the children's responsibility to choose rich parents. They didn't choose their parents or where in the country they grow up. But the income of their parents or where they happen to be born really matters, and government policy could make a difference, and it isn't. I've forgotten if you've got a Democrat or a Republican in the White House. It doesn't seem to make any difference, does it? And I'm not a politician. I'm not the least bit political. I couldn't care less who you have in the White House. I care about child poverty. Now, I said there's variation around the land. I was invited to Birmingham, not your Birmingham, our Birmingham, in the Midlands in England. They said, you've got to come because we have 6 Marmot champions, one for each of your 6 domains of recommendations. I wanted to see what a collective of Marmot champions looked like, so I went to Birmingham. And in Birmingham, they've had evidence-based programs to look at child development, children's physical health, literacy, numeracy, and so on, family nurse partnerships, which were developed and evaluated in the United States, effective programs developed and worked out here, Incredible Years parenting programs, and so on. So here's early child development in Birmingham. Birmingham is more deprived on average than the rest of England and than the West Midlands where it's located, but we didn't worry about that. They implemented these programs, and look what happened in 3 years. They closed the gap. What a generation. 3 years. Wow! That's terrific. I've got people in England beating a path to Birmingham's door, saying, what did you do? We want to do it too. Should doctors be concerned about this? What else should you be concerned about than giving children the best start in life? And programs make a difference. So while you're waiting for the level of child poverty to be reduced by taxes and transfers, let's get good evidence-based programs that would make a difference. Now, this is a particular issue in Britain. We have a scandal of the level of fuel poverty in England. People growing up in cold homes. We know about the excess in mortality from cardiorespiratory disease. I didn't know until we did this report that it affects children. This is the number of years out of the last 5 that children grew up, for example, in inadequately heated homes. And this is negative outcomes on illness and disability, smoking, drinking, being bullied, and so on, various bad outcomes for health. The more years they spent in an inadequately heated house, the more bad outcomes they had. We even see that children do worse at school if they grow up in a cold home. Now, some of you will have met the former chair of council of the British Medical Association, Hamish Meldrum, who grew up in Edinburgh. When I showed him this, I won't try and get his Scottish accent, even if I could, you wouldn't understand me. And Hamish said, when I was a lad, we had ice on the inside of the windows. So you can't tell me that growing up in a cold house can be bad for children's development. I said, Hamish, can you imagine what you might have achieved in life? Workforce as advocates. Doctors are listened to. We're held in high regard. Doctors are listened to. And some of us are concerned about the health of our patients. Yeah, concerned about income and pay, working conditions, politics and all that. Forget that. Forget why some of us, and remember why some of us went into medicine. We wanted to improve the health of our patients. That's what we wanted to do. And if there are things happening in the social political environment that are having an adverse impact on the health of our patients, we should be the advocates. I could show you British data, but I'll show you US data, which I'm sure you know. This is what's happened to the 50th centile of household income from 1970 to 2005. Scarcely changed. That's the 20th, the 10th centile, scarcely changed. The 80th centile, the 90th centile, and the 95th centile of incomes. So yeah, the economic growth has been really good for a few people. Let's look at the top 1%. You probably know these figures. In 1928, the top 1% in the US had 23% of total household income. You remember what happened next after 1928? Yeah? Everything came tumbling down, including the share that the top 1% had. During the period of the 1950s and the 1960s, the US economy grew every year steadily, 2.5%, 3%. The GDP grew every year. It was the success story of all history. The US economy, steady growth, capitalism flourished, everybody was getting richer. And how much did the top 1% have? 10% or less. Then it took off, and in 2007, the top 1% had 23%. And you remember what happened next? Now, I'm a careful scientist. I would never say that correlation is causation. I would never argue that it's been proved that the unconscionable greed of the top 1% brought the world's economy to its knees. I've got to admit, it's a credible hypothesis. And who benefits from that? Now, I can tell you about Britain, and I'm sure it's true in the US. Population surveys in Britain show that the population do not think that everybody should have the same. The population is entirely tolerant and think that income inequalities are absolutely fine, and that's the way it should be. People with more skills and more responsibility should be paid more than those less. So that's what they believe in Britain, and I'm damn sure they believe the same thing in the United States. People do not believe that there should be no reward for hard work and success and achievement and so on. There should be, but it's gone too far. That's what they believe. It's gone too far, and it's not benefiting anybody. And there are two issues with it. One is the minimum income for healthy living. And the second is that spending on reducing child poverty, spending on improving education, spending on improving neighborhoods is not possible because these guys don't want to pay their share. Because neither you nor we have anything that resembles a progressive taxation system. Doctors as advocates. And in Britain, this is child poverty. Child poverty had been coming down under the previous government. Because of the economic crisis, This is the dotted line, is the prediction of what would have happened to child poverty. It would have gone up. This is what's happened because of the coalition government's reforms. Child poverty has increased as a result of government policy. I've talked to cross-government department groups of officials and say, I'm not political, this is what the figures show. This will damage early child development. This is government policy. As doctors, as people concerned with health, we need to look at the effect of other policies on the likely impact of health and health inequity. I will say that when we produced that report that I showed you, we got sign-up from 19 different medical and health groups. They all gave us written commitments that they will seek to implement, the nurses, the social workers, the GPs, pediatricians, all these different groups. It's really encouraging. People are taking this really seriously. I said I wanted to indulge myself just 2 minutes, the European review, having just got all excited. So we said that health inequities persist within and between countries in the European region. The European region includes all of the former Soviet Union, Kazakhstan, Kyrgyzstan. It stretches from Portugal and Iceland. You can nearly touch Sarah Palin. I mean, it goes, it nearly reaches Alaska. So it's a very diverse region. And well, you laugh. And the life expectancy gap is extreme. We've got at least a 15-year gap in life expectancy. And what we show is even in the better off countries like Sweden, there is a life expectancy gap by education, and it's not getting narrower. It may even be getting worse. And in the Russian Federation, it's getting much worse. So the inequities within and between, in the best off and the worst off, and everybody in between, within and between countries. And we took a very similar approach to my English review, life course stages, the wider society, macro level context, and systems. We said health inequities are unnecessary, avoidable, and then just this photo, by the way, is a small number of the 52% of Spanish youth who are unemployed. 52% of Spanish 18 to 24-year-olds are not in employment, education, or training. These are the indignados who are taking to the streets and saying, we don't like that. Our futures are blighted. So we said good quality parenting, family building, gender equity, adequate social protection, social inclusion, equity at older ages, action across the whole social gradient. And I'll show you one more bit of data. What this shows is the likelihood of being in poor health by education, primary, secondary, and tertiary. And countries are classified by how generous their social expenditures are. So these are countries that are relatively ungenerous in their social expenditures. They have a bigger social gradient in poor health. The more generous the social expenditure, the narrower the social gradient. Policy makes a difference. And we said, do something, do more, do better. If you're in a country that's doing nothing, if you're in Kyrgyzstan and there's no social expenditure, do something. And we could tell you some of the things you could do. If you're in a country that's doing some things, do more. And if you're in Sweden, you can do it better. You can, and we can. Thank you.
Thank you very much, Sir Michael.